How official do we look after that? The sound effect and the graphic there, Erik?
So pro. It's awesome. I love it. It's great.
Erik Moen back on OrthoStatic with us. Thanks for the time, Erik.
Yeah, you are so welcome. It's just really a pleasure to be here.
What's your like 15-second superhero backstory? I mean, you've got the bicycle in the background. You're a physical therapist. I see a bike. What should people know?
Well, I don't know. I've been riding bikes for all my life, and bike as part of clinical practice has really been there since day one when it wasn't really a thing. And so I'll say that I'm one of the earlier people to adopt clinical bike work or bringing bicycles to the clinic, and I have a sordid past of just lifetime cyclist, recreational cyclist, also licensed racer, licensed coach, educator in bike or bicycle clinical work, and currently I'm working with paracycling at the international level, where I'm head of Paracycling Classification for the UCI, which is the International Cycling Union.
Was this in the cards when you started? Like, did you ever expect any of this cool stuff to happen, or it's one of those fun things that happen along the way, like all the different places that cycling and I love that yes and, right? That's the one rule of improv. Right. I would say yes and.
Right.
You just yes anded your career. You're like, I'm a cyclist. Okay, I'm going to be a PT. Like, ooh, what would happen if I yes anded this? Like, was this in a plan, or is this happy accidents along the way?
I have to say that I had early visions of doing bike stuff, and really a lot of what my early interactions of clinical bike work were actually more centered around me trying to figure out how I could participate at a higher level in cycling, because I have, we'll say, orthopedic dysfunction in a lower extremity, which actually, interestingly enough, qualifies me for paracycling. So I could be a paracyclist because of my impairment. But at the time, it was really not well known around the United States what paracycling was. So I was just trying to keep up with the people with two normal legs, which created a need for me to figure out how to change or alter my equipment to get best mechanical advantage. And so at the time, there really weren't many people doing it. So at all, or if they were in a very distant place, or maybe they weren't able to answer my questions or creatively problem solve with me for my issues. And so I was just like, the heck with it. I'm going to do it myself. I've got an inquisitive brain. I know how to research. I've got my physical therapy background, and I was talking to someone about this the other day. Like, as a youth, you kind of get inklings of what people are going to do. Like for example, like my daughter, she's always been a runner, but she's a runner. And so, like, for me, I was always studying movement, motion, like coaching skills. I remember tearing articles out of magazines about like certain sport technique. So there was always that kind of interest in biomechanics and biomechanical function, pedagogy, or learning a sport skill. So it all kind of fits in. I guess was it incidental? Did it kind of fall upon me? I think we make our luck, so to speak. And so a lot of the work that I've done has created opportunities, and it's hard work. It's not like, oh, I just get lucky and something gets thrown into my lap. I mean, that happens to people, but I'd like to say the hard work I've done and the good work I've done has helped create these situations where I've just kind of moved along.
It's such a shock, right? We get really good at things that we're excited about working hard on. And it's, of course, not luck. It's because you've decided, I like this. This is worth working hard on. And then you put a lot more time into that. And then suddenly you stop and look back and you're like, wow, look how far I've gone. I've learned a lot. How can I apply this?
Yeah. Frankly, for this whole bike niche genre thing, for me, it's like, it's dessert all day. So it's not drudgery. Like this week, right now I'm at the peak of my season because everybody's riding bikes. They've got a bunch of events and they're getting new equipment. And so I have a really onerous schedule that I've made this problem, but like last night I saw people till 10 p.m. And so, I had a 7 a.m. start and I ended up seeing people till about 10 last night. And so and it's kind of been that way for the last month. And so but it's one of those things like it's good fun. It's not drudgery. It's not like I'm like, oh, I'm burned out because, this work task really stinks. And so it's just like, if they're willing to come that late, I'll see them because I don't mind doing this stuff.
Because this is the time of year. And that's something that a reason we're doing sort of this, and you're kicking off sort of a mini series that we're doing with a bunch of different physical therapists who are yes-anding. Maybe that's the name. Maybe that's what we'll call the series, Yes and PT, which is you take this background and you put it together with something you're passionate about that other people in the public too, and you get something that is greater than the sum of the parts.
Right. That's really pretty awesome, Jimmy. The yes and is taking the opportunity to go just a little bit further than just kind of your typical circumstances. There are people who like to just clock in and clock out, and I respect that, but I don't know. It's so much more exciting when you take that yes and step, really. So brilliant.
Well, let's get into it. So this is really designed for the physical therapist who maybe didn't grow up with a cycling background, but they're seeing people in clinic and maybe they feel they have this sort of feeling in their gut. I know I had it when I was working with someone who maybe I didn't know everything about their sport, but I wanted to know. So this is sort of like the introductory guide with, hey, you got a patient on your schedule tomorrow. They've mentioned in their intake form cycling, or maybe they're coming back again, or you're seeing a patient from one of your colleagues. The information that we're going to give is really introductory, but can take you the long way. You're going to get the most miles per gallon of information. You're going to be really efficient. So let's kick it off with this. Most common. What are some of the most common orthopedic injuries that we're going to expect from somebody who self-identifies as a cyclist? Meaning, either they dug the bike out of the garage this year and dang it, this year I'm going to do it. I'm going to be a cyclist, or they've been riding for a long time.
Well, the most common thing is usually around the knee, and it's most oftentimes the front of the knee. It's most oftentimes irregular compression around the patellofemoral joint. That's really the most common. And then probably the second most common is we'd say low back pain or pain around the back. And that's more just postural stresses and strains. There's certainly positions and functions on the bike, which will set that off. Also, I think the other thing to understand is that bicycling's not walking. We're the human body. We walk, we run, we hunt and gather, not on a bike. And so bicycles were born around the 1800s. And so there's something that takes specific adaptation to. And so when you have a person with strong motivation and excitement to get on the bike, they're probably not going to have the strength, the coordination to just jump on a bike that's maybe not well positioned for them. And so oftentimes back and neck pain come around. And then also it's really kind of around the contact points after that. So it's like hand pain, hand numbness, foot pain, foot numbness. Those are really the common things. Also, the unspoken, the not often, well, more commonly talked about are the saddle discomforts, pain, numbness, my butt hurts.
And this was one of those aha moments I had as a PT student when someone framed it this way. And then I took this thing that they taught me and I sort of put it in a lot of different places, which is, hey, as a cycling physical therapist or a physical therapist who works with cyclists, they framed it as my job was to move the bike to be comfortable for the human, not to tell the human to be comfortable for the bike. So essentially adapt the bike as much as you could so the human could be optimized on that, or to reduce the pain or the discomfort. And that led me to my first aha moment, or my second aha moment, which was I bought my first bike on eBay because I was, dang it, I'm going to be a cyclist. And I did. And then this is 2-3 years into me riding a bike. It was a It was a bike with aero bars.
Mm-hmm.
And I was riding them, and this is for the YouTube viewers. I was riding them, and I didn't realize that the handles, the extended arms,
Yes,
they telescoped, and they were telescoped all the way in, and my arms were longer, so I was riding with my wrists completely flexed to change the gears. And someone said, "That's an interesting position. Why do you ride like that?" And I said, "Well, it's because my arms are longer." And they said, "You do know that little screw right there loosens, and you can shoot those things in and out." And I remember the entire ride just thinking how smart I thought I was 10 minutes before and how dumb I now realized I was. I never thought about it. But when you now look at a bike and you go, oh, a lot of the different parts can be moved so the human is actually comfortable.
Yeah. Yeah, it really is amazing when we deal with the human on the bike, how many different variables we're managing and how much you know about the adaptive parts and pieces that are out there and available to put on a bike, and the ones that can work and can't work, and the ones that can imply your ability to safely ride a bike. Because honestly, there's some adaptations that are just unsafe and not appropriate for the inclusion to a bike. And so we have to be careful of that. Just to kind of back up a little bit, that whole your aha moment about the adaptability of the bike or the adjustability of the bike and the adaptation of the body, that was kind of first made popular by a guy named Andy Pruitt, who's done a lot of work, early work in this clinical scene, or kind of was on the earlier side of making it popular. He would have a slide of this groom with their bike on the wedding altar, talking about the marriage of the body to the bike, and the bike is adjustable and the body is adaptable. And so that really is kind of carried out to where you know that was probably early 90s that he had that was on his slide deck. And so it really is, that's really an important concept that we carry forward, is the adaptation of the bike position, and acknowledging that the body also has to make some changes.
Yeah. And understanding. So you really sort of, and for the person who's listening to this right now, who's like, well, I'm not really a bike expert. But you do bring a lot to the table as a physical therapist. First of all, understanding, I'm imagining what's going on or why might that happen. And then you get to think backwards, which is, okay, how can we use what I know about biomechanics and what I can learn about bicycle geometry or bicycle mechanics to make this activity more enjoyable for the person and be able to do it better, pain-free, whatever their issue might be.
Yeah, 100%. The physical therapist is really uniquely qualified to work in this space because of what they know about the human anatomy and human biomechanics, knee function, adaptation to strength, mobility, our ability, day in and day out, when people talk about, oh, my right leg is doing something dorky, we can look at the bike and try to do adaptation of the bike. But if we don't have the perspective of, hey, their hip is just crap, it has no mobility, closed pack position, I can't even, that's the bigger picture, is if they have that limitation, impairment, immobility, that's the bigger driver of how we take, we'd say, adaptation or adjustment strategies on the bike. So it really, what we know as physios is really super critical towards, we'd say, most efficient, effective adaptations to the bike.
So let's talk about assessment, right? That's a PT term. That's something PTs are pretty familiar with doing. What are maybe some differences or some techniques or tools that you might use with a cycling athlete that maybe someone who hasn't treated a cyclist before might not be accustomed to or might not think about?
Well, I think when we talk about assessment of the cyclist, really the important thing is to start with the subjective. And so the subjective piece of it, I spend some, I'll say my practice right now is cash based. So I'm I'm not like, oh gosh, I got to get this person out of here in 20 minutes sort of thing. So I take the time to ask questions, because if I can ask some good questions, they're going to tell me what their problem is. And I think that's the challenge with today's healthcare delivery, is we've lost that connection and ability to ask good questions of our patients' clients. And so when so it starts there, and it starts with asking good questions around how they're using their equipment, when they started, what's their development as a cyclist, what's their have they had any bike crashes, just sorts of like how they developed. Are their pains only related to the bike? Do they have pains with other things? Do they have any past medical history? And so really that's probably the most critical thing. And then really when we talk about working with cyclists, the piece that sometimes the physio may not have is the ability to evaluate the person with their equipment, which is critical to me. It's like if we're physios, we watch people walk, right? So we watch them walk in. That tells a lot about who they are, what they do, what their impairments might be. If we have a runner, we watch them run on the treadmill. Why wouldn't we watch a person on the bike? So really, when we talk about the assessment of a bicyclist, we have to look at them with their equipment and on the bike if we're going to truly treat them. And what I tell physios, physical therapists, is that if we're able to see them with their equipment and have like reasonable physical examination with them, we can come to resolution pretty quickly with regards to their problems and issues around the bike. I often tell this story, like the typical deal is a person may come into a physio office and they get treated for knee pain for the bike. And, they go through the different exercises. They're like, oh, you've got a weak glute medius. I'll say every cyclist has a weak glute medius, and it has nothing to do with their knee pain. But when you get them on their bike and you see that their cleat position is totally off, if all I do is change the cleat position, their knee is magically fine. And so it takes one visit to appropriately, effectively intervene for this person, and they're back out riding their bike just happy and healthy. And so really then the evaluative tools around the bicycle are very simple, simple goniometer, gravity-based tools like levels and plumb bobs. There's lots of fancy tools that a person can use in evaluation, but really for most people, those fancy tools, they can lead you asunder, and they're full of error sources. So I would say for the vast majority of people, using the simple tools and understanding good questions, good understanding of the physicality of your cyclists, you can treat them very well and get great outcomes.
Yeah. So even something as simple as a bike trainer that you can put that human on and get them in the cycling motion, that's low hanging fruit. Yeah, there it is, right there, right?
Yeah, I set this up in the background, but this is just a bike set up on the trainer. We level it up, and then I look at the bike for forensic information, like their handlebar position, their saddle. What's their saddle look like? Is it roughed up in one area? It's kind of funny as I'm getting on in clinical exam. It's just like pattern recognition.
Sure.
If what you do in physio is you're like a SI specialist, like your sacroiliacs are you. You see a person walk across the room, you're like, oh, there's their problem. And so it's kind of at this point to where I can have a bike walk. I'll have a bike walk in and be like, oh, don't talk. Let me just fix this. And I mean, it's not. I don't exactly do that, but it's. But there's some things that you're like, oh my gosh, you've been riding this way. And so, if we just do some very simple things, but it starts with seeing their equipment.
Yeah.
If we see their equipment and understand how they're interacting with it and how they're developing, or how they're able to hold postures, how they're able to move in the pedal stroke, what gears they're using.
Sure.
Those are all super important bits of information towards understanding why they're visiting you with their dysfunction.
You could have saved me a lot of time and effort and pain when you saw me riding like I had T-Rex arms. That would have been that would have been a Phillips head screwdriver in about 30 seconds.
Save the date for the 2024 AOMPT Conference, October 23rd to the 27th in Orlando, Florida. Join OMPT professionals for 5 days of continuing education focused on OMPT, hands-on learning, research, networking, and more. Visit aaompt.org for more information.
But you touched on this a little bit in terms of equipment customization. What role does equipment customization play in treating cycling injuries? It sounds like, by pointing out that their cleat position is actually the thing that a little modification can go a long way.
Yeah.
You sort of have to, if you're going to continue to see these athletes, you got to get more familiar with what can you do from that end, I'm imagining.
Well, I think that's the biggest challenge of the physio getting going in bike is just understanding the mechanical aspects of it and understanding which equipment is safe to use and how do I even turn a screwdriver.
Sure. Because these are not cheap, just so people know. Like, you start messing around with Cyclist bikes and you're not doing it right, they're not going to be happy people.
Yeah. So for example, my last two bikes last night, one was like a $12,000 time trial bike. And then the next one was like a $12,000 e-road bike. And so, I mean, there's a level of maturation in how you serve this group and how you take care of their equipment, because I mean, you don't want to dork their equipment in your office space. And then you need to also respect that a lot of this stuff has weird mechanical attachments and fixes. And then also understanding your scope of practice, like, can I make this change? Or how do I partner with bike shops? It really is no different than what we do in clinical practice, in the sense that we have our scopes of practice where, there's things that are appropriate for us to do. And then there's times where we need to refer out for further interventions or more appropriate interventions. And so that's really how there's things that I can do. I've been wrenching on my bikes for years, since I was as a little kid. I've always been mechanically interested in turning wrenches on my bicycles. And so there's that background knowledge that, bikes not to give away my age, but, I'm secure in my age, so it's fine. But, back in the 70s, I was tearing apart my bikes all the time.
Sure.
And so, and the bikes these days are very different. We've gone to much more technically intricate bikes and that require special attention. And so it's not just like, oh, I'm going to take a weekend course on bikes and then I'm going to be a bike fitter. It's like, oh my gosh, I need tools. I need to have the perspective of how to attach these bikes to the stand. Just simply attaching a bike to a stand these days is not easy.
Sure.
There's some trickiness to it. And so this type of practice, I'll say, is not for everybody. And really, you almost kind of have to be the triple threat, if you will, of clinicians, where physio, some bike background understanding, and then mechanical skills. So you really, it's just like your example of fixing we talked earlier before the recording, you had that you were out riding your bike and you didn't know how to fix a flat. And It's like, if you don't know how to turn these wrenches and appropriately tension bolts to parts and pieces, that one exposes you to liability. Two, it doesn't help your patient client. So it really, you do have to, as much as people have enthusiasm for this, you do have to have some base understanding of these things. And really, when I'm working, I pretty much only see bike. I have a little tiny bit of orthopedic practice these days, but it's all bike. And so, but to have that array of like bikes that come in, I have like from the 70s bikes all the way up to today's bikes, which are vastly different in how we can adjust them and adapt them.